Hi, everyone. Welcome to this continuing professional development program. It used to be done on a Thursday at 3 to 4 as part of the Department of Family Medicine in the Johannesburg Health District. We've now moved it to being an African Forum for Primary Healthcare, CPD, and we're using that as a base to provide CPD to people from across Africa. Certainly people from Chris Hani Barra appreciate that they're a hospital that services not just South Africa, but large parts of Africa. So we're very fortunate today to have Dr. Sarah Swartboy, who's an orthopedic surgeon, together with Professor Sebastian Magabotha at the University of Witwatersrand and based at the Chris Hani Baragwanath Academic Hospital in the orthopedics department. And they're going to talk about the management of joint pains and arthritis. Dr. Swartboy, thank you very much once again for doing this continuing professional development lecture with us. Are you able to share your screen and manage?
Good afternoon, Prof. Thank you so much. It's a privilege to be able to actually join and be part of this program. So thank you so much for the warm. Let me just try and share my screen.
You can also share a video. It might be if you feel comfortable with that. Not true. All right, that's fine. You can share your screen if you're having difficulty. I'll just check. You emailed it to me, I think.
Is it visible?
Seem to be managing. Yeah, you're going fine.
Great.
Good. Well done. So I'll leave it to you. For those who are on the call, and thank you, we've got a great attendance. Please use the Q&A at the bottom to ask your questions, and we'll try and finish with enough time to answer some of those questions. Professor Magabotha promised that he would also join us, and he would also speak and answer some questions if you need. Thanks.
Yes, please. If I could make a small request that you please stop me at any time to ask any questions. If there's clarity that's required, something to be repeated, I'm very, very open. I prefer a dialogue as opposed to just a one-on-one or one-sided communication. So please feel free.
Sarah, so quickly, I just want to ask if you can please put in this demographics so that Sarah also has an idea of who's on the other end, and that'll help her to communicate with you. It's mostly family physicians, medical officers. So I think there might be interns as part of that. So I'll include it in the next time so that you can see which percentage are interns.
Okay. I see something on my screen flash for a second, but I just panicked because it was blocking my view. But
no, it's fine.
Prof,
I'll just share it in a second, and then yeah. Well, let's end the poll now. There's about 69 people, and I think let me just show it now. It's mostly medical officers, so you can see who's here. And I think that gives you a sense of it. We can repeat it at the end of the session as well. Great. Thanks. You can proceed, Dr. Swartboy.
Right. So thank you so much once again for the opportunity to present to and represent the University of Witwatersrand, the orthopedic department. And this is just going to be a brief presentation as to the management of strains, sprains, contusions, and bruises, and how to differentiate the differences between these and the implications of actually missing them and not actually being able to diagnose them. Okay. So in terms of definition, a sprain refers to purely to a ligamentous injury. When we discuss ligaments, a ligament essentially is a structure, a fibrous or a connective tissue that connects bone to bone. And a strain, however, is any other soft tissue injury. So that could include that of the tendon, it can include that of the muscle belly, it can include that of the menisci, it can include just a soft tissue injury or purely just the subcutaneous fat or the skin. However, a sprain is completely a different kettle of fish. It's purely a ligamentous injury that's involved. So I want to start discussing sprains most importantly, because those are a very common orthopedic condition, and they present quite commonly, and the consequences of actually missing them can be quite devastating. I would like to start with just essentially discussing the ligamentous, the grading of ligamentous strains. Type 1 is when the patient presents with pain and swelling of a specific joint, and they are able to wait there. There's no instability of the joint. And we grade it as 1 because the majority of the time, there's some stretching of the ligament, but the entire ligament itself is not torn. There might be some tearing of some of the fibers of the ligament. However, the majority of it is intact. Grade 2, I'll have a picture. I'll have a picture on the next slide, which just to show. But grade 2 is an incomplete tear. Usually, most of the fibers are actually torn, but it may lead to instability, but the patient is still able to wait there. They still also present with significant pain and swelling. However, they actually can be managed non-operatively, and though their outcomes are not as great as grade 1, they actually can improve to full function. Grade 3, however, is a complete tear, and these patients present with marked instability of the joint because ligaments tend to cross the joint. And what happens is that they present with marked instability, severe pain, inability to wait there, should it be the lower limb, or inability to do activities of daily living, or have muscle weakness. So this is just a picture depicting the different kinds of strains that you can find. As mentioned, you can have a stretching with some slight tearing within the substance of the ligament itself. You could have a larger, grade 2 is larger, where you have an incomplete tear, as mentioned, and grade 3 sprain is a complete tear, which is sometimes also regarded as an avulsion injury. But we'll go into depth as to what forms that we actually get, forms of sprains that actually occur commonly within the orthopedic department.
Sarah, may I just quickly in between just help my thinking? Do you mean that, do you use the weight bearing as a critical differentiator between
absolutely.
grade 2 and grade 3? So
Absolutely.
essentially, grade 1 is no instability, but grade 2, grade 3, there's some instability, but if it's grade 3, they can't weight bear. If it's grade 2, they can weight bear.
Majority of the time, especially around the ankle and the knee, when it comes to a grade 3, they're usually unable to weight bear.
So that would be a grade 3 when that happens.
Most especially in terms of an acute injury. I have mentioned a bit of degenerative, because you do have degenerative sprains or stretching of the ligaments, where the patient will present with a severe deformity of a limb, which is unstable. However, because of the fact that it's occurred over time, they're able to weight bear. But in the acute setting, which is usually less than 6 weeks, they are unable to wait. In terms of a grade 3,
so
they have
it's more the acute setting.
Loss of function. Yes, yes, exactly. Severe loss of function, as well as a significant instability around that knee, that ankle or knee or joint.
Thanks, very useful.
So in terms of sprains, we talk more specifically in orthopedics, we talk about muscles, or we talk about the muscular tendinous junction. And as very similar to sprains, we grade them according to grade 1, 2, and 3. And these pictures, I think, depict them quite nicely, which shows that you have some stretching or you have some bruising or contusion of the muscle, or you can have a partial tear through the muscle, which involves 50% of the muscle or just under that, or you have a complete tear through the muscle. So in terms of mechanism of injury, as mentioned, you can have an isolated traumatic event. You can have recurrent or what we call overuse injuries, and also that of degenerative, where the patient essentially presents you with osteoarthritic changes, and due to the pathology and the pathophysiology of osteoarthritis, they present with ligamentous instability. So I just wanted to mention specific areas, anatomical areas that are pretty common, pretty common presentations within the orthopedic department. One of which is the ankle sprain. And I think it's also not only within orthopedics, but also in terms of primary health care. You'll come across this quite often, where you have a patient who presents to you with inability to weight bear with significantly swollen ankle. However, when you look at the X-ray, looks pretty normal. So they somewhat innocuous injuries where you tell yourself that, okay, fine, they just need some rest and they should be fine. However, it's important to be able to evaluate your patient and encompass all the different findings to make sure that you're actually not sending home a patient with a grade 3 form of a sprain. So this, in terms of just the mechanism of injury of the ankle joint, you have your inversion injury, which is the most common injury, as mentioned, as you saw that the picture that was depicted earlier of the soccer player basically rolling his ankle while running. You have the most common presentation is lateral collateral ligaments that are involved, and these patients will present with pain on the lateral aspect, significant swelling, bruising, depending on the grade, as mentioned before. They able to weight bear or unable to weight bear. However, the pain is most specifically on the lateral side. In terms of inversion, it's far less common, but that essentially involves the deltoid ligament, where they actually have inversion and external rotation. However, this is more common with ankle fractures. So, but you can essentially get a deltoid ligament, isolated deltoid ligament injury. But most commonly, we see the inversion form of injury in terms of the ankle. Going up further, we started to mention injuries around the knee. Most common are our collateral ligaments. Is anybody able to tell me in terms of anatomy what the collateral ligaments are? My apologies, I like to ask questions just to make sure that my audience is awake. Yes, fantastic. Shiraz?
Are people responding on the
yes, Shiraz has his hand raised. Yes.
All right. Are they raising their hands? I'd need to allow them to talk. Okay, Shiraz, you can go for it. And Tasneem, you can unmute yourselves.
Hello, I don't know if you can hear me.
Hi, Shiraz.
Hey, so your collateral ligaments consist of your medial and lateral collateral ligaments, which obviously occur on either side, adjoining your femur and your tibia, and then obviously they provide support in preventing lateral or medial deviation, I guess, of the tibia on the femur.
I like that, Shiraz, but more eloquently said would be would prevent your varus and valgus, or that essentially assists with your varus and valgus constraint, correct?
Yes, I would agree with that.
Yes, and then in terms of your cruciate ligaments?
So you have your anterior and posterior cruciate ligaments. Yeah, that's as far as I can go.
Yeah. Yes, but how do they assist in terms of stability around the knee?
So I think they basically prevent anterior-posterior displacement of the tibia on the femur, if I remember correctly.
Exactly right. Exactly right. Fantastic. Thank you so much. Does anybody know what a traction apophysitis is? It's a quite a tricky one. It's something I also only learned as a medical officer within orthopedics myself. But I'd like to give you guys an opportunity to discuss it with me.
If you pick up your hand, I can give you a chance to respond. You can also use the chat function. So if you want to volunteer an answer there. All right, I think people are struggling with that one. So what is it? Yeah.
Let's give them a chance because I recognize some of the names.
All right. So you've taught them and they should be telling you the answer. All right, pick up your hand if you can.
Okay, that's not a problem. So
it's hiding in anonymity. So, okay.
So
go ahead.
Essentially, there's different forms of traction apophysitis that occur. It's essentially a form of it occurs in children or in adolescents, essentially, where you actually have pull of the ligament, and instead of where the ligament is actually giving way, you actually have like an osteochondrosis or involvement of the physis at the level of where the traction actually is. So the common forms that will actually come to present to the primary healthcare physician will be the Osgood-Schlatter disease or your Sever's disease, where you actually have a young male who's an avid basketball player who does a lot of jumping and leaping and squats, etc., who's complaining of anterior knee pain. And you look at your X-ray, you see that there's a slight gapping in the physis. However, he's excruciatingly tender over the tibial tuberosity, and that should give you an indication of a possibility of a traction apophysitis.
So just quickly, the key is that it is an age group related, young, active, and it's tibial tuberosity, so it's not quite the knee, it's slightly lower.
It's slightly lower down. Yeah, but they do present, however, you know, with children, it's actually very difficult sometimes to localize the pain exactly, but they will complain of knee pain. But I think it's something that should be top of mind. If you look at your X-rays and you don't see any abnormalities, or you see a slight gapping within your physis anteriorly, I think that Osgood-Schlatter should be top of mind. Traction apophysitis can occur in different sites in adolescents and children. It can occur within the calcaneae, that the apophysis of the calcaneus, as well as the olecranon, due to traction of the triceps muscle itself. So it's also very important that you're able to know the involvement of not only just the ligaments that attach or the tendons that attach, but also, especially within adolescents, the physis, which is extremely important. So just going up more proximally, we can talk about the hip and the pelvis. A common form of strain is the adductor strain. And these patients usually present with, depending on the degree, as mentioned prior, they present with groin pain. And usually it's actually quite difficult to detect or to actually decipher where exactly the problem is, because sometimes you're concerned about the fact that it's involving the neck of the femur or something higher up. But with thorough examination, you're actually able to palpate and feel that there's actually the adductor, that's the adductor muscle mass that's involved. And these patients do quite well. The investigation of choice is an MRI, which is actually quite difficult to get, but these patients do very well with just some rest or RICE, as we'll speak about later. So just in terms of grading of your muscle strain, from grade 1 to grade 3, they will all complain of pain. From grade 2 to grade 3, I think this is a fantastic chart. Where if you have grade 2 and grade 3, which they'll actually have a weakness. So does anybody know how to grade power? In terms of muscle strain. I'm tempted to pick on Shiraz again because I'm pretty sure he knows.
Hey, I'm assuming, do you grade power the same you would for neurological
Yes.
exam? So
Yes.
then you grade it
Share
1
with
to
us.
5.
Mhm.
So 1 is full power, 4 is slight impairment or slight weakness. 3 is somewhat decreased. 2 is inability to raise against gravity, and 1 is 0 is no power at all. 1 is a slight flicker, if that's correct, I think.
Okay, I think you should start from 0, Shiraz, and work.
Okay, so 0 would be no power at all, so no movement at all. 1 would be a slight flicker of the muscle. 2
Yes.
would be ability to raise against gravity.
Yes.
3 would be slight weakness. 4 would be moderate weakness, and 5 is full power against resistance.
Okay, I like that, Shiraz, but I would just add that you mentioned with 2, with gravity eliminated. So basically, that means that in the face of no gravity, so this patient can actually, what they do is that they can when you examine them, is that they're able to slide the limb in a specific direction, or if you actually hold the limb, they can actually perform the function that you want. However, if you, for example, if you're trying to test the triceps and you hang the elbow down and ask them to actively extend, then they are unable to, and that means that with gravity, they're unable to. And grade 3 is that they're able to actually extend, for example, the triceps muscle. With you actually holding out the elbow, holding out the arm in the shoulder in abduction, and they're able to extend, that gives you a grade 3. And then grade 4 is that the power is they have against gravity but not resistance. So they're able to resist gravity. However, if you actually push against them, you'll notice that there's a significant difference. Hi, Elaine. I see your
Sorry,
hand.
Dr. Yes, sorry. I just have a question about the traction apophysitis. Sorry for going back. I just want to know, what's the difference between that and like a chondritis, osteochondritis?
It's the same thing.
Okay, cool. Okay, cool. Thank you.
Yeah. Okay, I think that's well answered, and I think that this is a very nice chart just for you to basically assist you to say, okay, fine, if a patient presents with some form of and a nice common one is actually the Achilles tendon. I hate to pick on Shiraz again. Can I just have a look at the names? Or anybody can tell me about the Achilles tendon.
I think Tasneem and Elaine could
yes,
they could
Elaine.
respond, but Tasneem as well. I think Afid, she wants to. If anybody else wants to answer, just pick up your hand and we'll give you the chance.
Hey, so the Achilles tendon attaches, so it's a tendon that attaches your heel bone to the calf, I believe, and very important.
Can I just ask you what muscles we're talking about when we talk about calf muscles?
So I think it's okay. So it's the calcaneus, the soleus, or is it the gastroc? I don't know.
They're complex, so you've got them both.
Got it right. You just pull them all.
Yes,
yeah.
Yes, so your gastrocnemius and your soleus muscles. That's correct.
Cool.
And then they attach.
I can't remember. Down,
You just
like they
mentioned it.
touch the calcaneus
Yes,
bone.
yes, right, to the
Yeah.
tuberosity.
Yes, yes.
So a very common injury that we come across is your Achilles tendon rupture. Can you tell me how they present? What is the history that they give you?
Me again.
Yes, you.
Okay, sure. No
classic?
problem. So basically the patient will if it's completely ruptured, then the patient will have loss of function. So basically the patient won't be able to extend their foot. They won't be able to weight bear. They'll have an immense amount of pain. I haven't seen one myself, but yeah, I'm assuming there would be quite a bit of swelling as well.
Okay, Elaine, can you tell me more or less in terms of the history?
Okay.
Do you know what the classic thing that they hear? It's usually what
like
we
a
call
pop, I'm assuming.
exactly, yes. We call them weekend warriors because they're sedentary throughout the week, and then they just feel the need to suddenly play soccer.
Oh.
So they call weekend warriors, and they decide, okay, we're going to kick the ball around. But as you said, a sudden loud popping sound within, and it's not immediately, they're not really sure where it comes from or whatever. There's not immediate pain, but they do present with sudden weakness. And then in terms of your weakness, what you mentioned something that was important.
So inability to extend the foot.
Okay, so when we talk
and
about
loss of function, yeah, they won't be able to walk.
So when we talk about the forearms and the foot and ankle, it's very difficult to say what is extension versus what is flexion. So we talk about
the plantar flexion.
We talk about palmar flexion or dorsiflexion, and we talk about plantar flexion and dorsiflexion. So which one? Because it's all flexion in my book. So which one are we talking? Are we flexing plantarly? Or are we flexing dorsally?
Plantarly.
So what will be weak?
What do you mean? The foot will be weak?
Yes, but which muscle? What is the
calf?
Yes, but which part?
I don't know. I select Shiraz to take over from here again.
Okay. There's a Nicholas. There's a Nicholas here. Oh, hi Nick. These are all my interns. Hi Nick, go for it, please.
Hi, can you hear me?
Yes, Nick. How are you?
So good and you.
Good.
So the gastrocnemius does plantar flexion.
Mm-hmm.
So the test you would do is the Thompson test.
Okay, before we get to the test, how would we examine this patient in terms of just if you put them prone, and what are you looking at? What will you see?
Well, ultimately, any orthopedic exam starts with gait.
Yes.
So after you assess the gait, they would likely have an antalgic gait. Then following on from that, it's always look, feel, move in orthopedics. Mm-hmm. So you would always look to see if there's any abnormalities, any deformities. Then you would feel the joints, feel the soft tissues for any tenderness.
And what would we feel for in an Achilles tendon rupture?
So typically you would feel a depression in where the Achilles tendon normally is. So just above the calcaneus.
So there'll be a nice gap there that you feel, hey?
Yes.
Okay.
And then on to move. So you move the ankle joint, and the special test is the Thompson test, where you squeeze the gastrocnemius and you should elicit plantar flexion if it isn't ruptured. But if it is ruptured, you won't elicit plantar flexion.
Fantastic. So it's a passive test where you're actually squeezing the calf yourself. And it's something that you should just try on your sibling or your partner. Just ask them to put their knees on the chair and just squeeze their calf, and you see that there's just this automatic plantarflexion of the foot without them actually trying to do anything. And you mentioned the test. What's the name?
It's the Thompson test.
This is either the Stevens test or the Thompson's test. And you also can notice, especially if you place the patient prone with the hips extended and the knees flexed, there's a loss of resting equinus. So there's always tension within the gastrosoleus complex that gives you somewhat of a bit of equinus. But because there's loss of continuity of that structure, their foot appears to be way more dorsiflex than it should be. All right, I think we can move on from that. Any questions? Okay, we move on. I don't know why it's frozen now.
Just click on, okay.
I
think you're working it.
Okay, so this is just a picture, a graph that I added just to show the muscles that are at risk in terms of muscle strains. Biceps brachii, we've seen quite a few of those, and I think it's self-explanatory as to why we see so many of these. You have these gentlemen that go to the gym and they want to do bicep curls and lift the heaviest dumbbell there is, and they present with essentially that form of injury. All right. Just in terms of the back, it's important to be able to elicit the difference between strains and sprains versus the actual pathology such as spondylitis or spondylosis. In terms of the ligaments, this is something that we've come across, especially with the interns that have worked with me. We've come across a lot of trauma patients who actually have what you'd regard as a sprain, but there's these structures are quite important in maintaining the normal sagittal balance or coronal balance of the spine, which means that the normal cervical lordosis and thoracic kyphosis, lumbar lordosis and sacral kyphosis. So all these ligaments essentially help to maintain these structures within their anatomical positions. So loss of one or more of these structures actually results in significant malalignment of the spine. So it's always important not only to look at fractures when you're looking at x-rays, but to look at the normal lordosis or kyphosis within within the spine. And then in terms of your strains involving your muscles, this is a very, very common presentation, especially within the emergency department if you're working in private, or within your healthcare, your normal CHC, where your patient is involved in a motor vehicle accident and they're complaining of lower back pain. However, as we know, we can't x-ray everybody, and mass majority of them, when you actually palpate, you will see that they, as opposed to having pain. So let me ask a question to one of the medical officers now. Medical officers out there, how do you elicit the difference between a fracture that you think is actually involving the vertebra versus a paraspinal muscle pain? What would make you comfortable to say that this patient is most likely has paraspinal muscle pain as opposed to something more insidious? I think the name kind of gives it away. Nick?
I think if you palpate along your spinous processes and you don't elicit pain, but if you palpate along the paraspinal spaces and you feel pain, it's more suggestive of paraspinal injury as opposed to actual bony injury.
Yes, and remember when we're examining the spine, we feel we feel for every single sorry, I've forgotten the word now, for example, but if you feel the spinous processes, you feel along every single spinous process, and you're literally trying to feel each one, is there equal spacing between each one, and is there any gapping? So if there's a gapping, that should be definitely a concern, that there's a possibility that we have a spinous ligament or there's something more pathological going on here. But absolutely, so if the patient complains of paraspinal muscle or paraspinal pain, it's most likely more of a strain more than actually a ligamentous involvement. So whiplash, I think that's one of the most common things that patients present with. It usually involves the cervical spine. You have this patient that's involved in a motor vehicle accident. They were restrained at the time. However, with the body and the thorax being restrained, you have somewhat of a hyperflexion motion of the cervical spine, which is usually in lordosis. So with that, you have tearing of either your ligaments, as mentioned before, or even slightly involving your musculocutaneous junctions or even your muscles. So it's important to be able to identify these patients. It's important to essentially X-ray these patients. I honestly, I'd rather just have an X-ray to assess, the normal lordosis of the spine, both do my AP laterals as well as my open mouth fuse. That's a talk for another day, but also examine them thoroughly, as Nick mentioned. You look, feel, move, and then there's actually specific criteria that I think should be homework for you guys to look at the Canadian rules as to who should get X-rays and who shouldn't get X-rays. But whiplash is a very, very common presentation post motor vehicle accident. So just going to the shoulder, there's quite a few different sprains and strains that you do actually get. The most common is your ACJ disruptions. And I think quite a few of you guys have actually come across them and seen the different types and how to manage. Can I ask anybody who, just out of interest, if we want to manage a patient who has an ACJ disruption, how do we manage them? If you want to manage them conservatively, how do we send them home? Do we just send them home with the arm hanging down? Do we place them in a cast?
So you have to immobilize the joint. You have to put them in a sling, analgesia, rest, and physiotherapy later on.
Fantastic. However, so if you're concerned, however, and you look at the AC joint, you can see that there's significant rupture of your coracoclavicular ligaments. What would you do?
I think most patients would need to go to theatre. If I'm
You'd refer them to me.
Exactly.
Yes, so you'd refer them on. Hey, you wouldn't send them home and say, the pain will subside, which it will, but the problem with coracoclavicular junction disruptions is that these patients actually have significant loss of function in terms of overhead activity. So if it's a laborer who has quite a large disruption and his job is to actually lift a brick and pass it up to another person, you significantly handicapping him by not actually referring him to your local orthopod to actually get him fixed. Okay? And then just going on to onto the elbow, There's the tennis elbow and the golfer's elbow. Does anybody want to just discuss it? It's on the slide, but just for interest's sake. Shall I pick on somebody? Oh, I can't see the names, Prof.
Anybody wants to pick up their hand? I think otherwise you've got the 4 to pick at the top, so maybe Tasneem can help you.
Yes,
Tasneem, it's on the slide.
Okay, so the tennis elbow is lateral epicondylitis. It usually causes pain on the outside of the elbow. And it's caused by inflammation or micro tears of the tendons that join the forearm muscles. And then, the golfer's elbow is the medial epicondylitis, which causes pain on the inside of the elbow.
Absolutely. And it's very important that you actually examine these patients quite well, because there's quite a few differentials that you can actually come up with that I don't think we should go into, but in terms of your tennis elbow, it's important that you, like you say, there's pain on the lateral aspect of the elbow, that it's important that you actually palpate and actually feel and also elicit the muscle strength of the lateral compartment prior to you diagnosing these patients.
And please, it doesn't need to be with golf that you get a tennis elbow.
Yes.
just remember, it's the lateral and the medial epicondylitis. Forget the sport, doesn't matter.
Yeah, I think we should do away with that as well, Prof. I think it's difficult to remember, and yeah, I think it's lateral epicondylitis or medial epicondylitis will do. Okay, so just going down more distally, we can just talk about the wrist itself, and all I want you to know is that patients can present with a fall in the outstretched hand, and they don't always have to have a distal radius fracture, any of the carpal bones involved. It's important that we know about the triangular fibrocartilaginous complex, that it actually does exist. Is that red? I got a nice picture that's showing that erythematous area over there, and they can actually present with, it's actually an entire complex anatomy, but it can actually present with tears that can result in quite a bit of morbidity should they not be managed appropriately. So it's always good to give them a trial of conservative management, and if you think that there's not significant injury or deformity or loss of function within that wrist, then you can, as mentioned, you can place them in a splint, rest them, ice, compressive dressings, and elevate. And in fact, if you feel after a week or so that you're not happy that the patient, or after 2 weeks the patient does not improve and the swelling is still significant, please do transfer to orthopedics. And then lastly, going down to the digits, it's important that we know we've done a lot, as mentioned. I know quite a few of the medical officers now within this group, they've come to the orthopedic department. There's many digits that we have reduced, but it's also important that once you reduce a digit, you must be able to think about the anatomy that's actually involved and what exactly has been injured, and what will do well conservatively versus what will not do well. And I think that it's important just to know that if there's a tendon injury, number one, if you think that there's a tendon injury, you look at the hand and you see there's lots of the normal cascade of the hand. And so I just want everybody to turn your hand. If you turn your hand with your palm facing upwards and you look at your fingers, you can see that they firstly, we're not in full extension in the resting position. Does anybody agree? Anybody can agree or disagree. Shiraz, what do you think?
Yes, I agree.
Okay, so what are you seeing when you put your hand just palm facing to the ceiling? What are you seeing in your hand? What is your hand doing?
So essentially, you have a cascade of your fingers. So kind of your fifth digit is much more flexed than the preceding digits, and then that kind of cascades forward in a normal situation.
Absolutely. Is Ariel there? Okay, I guess not. Kiara? Okay, no problem. So can anybody tell me if there's a loss, if you have lost sudden an injury to your flexor tendon of your middle finger, what would you notice when in terms of just the cascade of the hand or the cascade of the digits?
So essentially what would happen is, because you've lost that flexor tension to your middle finger, your extensors would take over and you'd kind of have predominant extension then of that finger. So then you'd kind of have a break of that cascade then.
Absolutely. So it will just appear to be more straighter than it should be, correct?
Yeah.
Okay, well, fantastic. So number one is your tendons. Number two is your collateral ligaments. It's a nice anatomical picture of the anatomy, just showing your collateral ligaments that we're actually thinking about when we reduce these fractures and what we're concerned about in terms of tears. The volar plate, extremely important, because these are the volar plate injuries are actually the cause of your traumatic boutonnieres. Boutonnieres is not only just confined to your rheumatoid patients, but you can have a traumatic boutonnieres deformity due to a volar plate injury. That's especially it's actually quite difficult to manage should it be neglected. Okay, so as mentioned from Shiraz, or I think it was Shiraz, from the very beginning, it's important to do a systematic assessment of your patient, which includes your history taking, mechanism of injury, the comorbidities, and the habits. In terms of your Achilles tendon, I think it's just important to mention that one, it's your middle-aged gentleman who wants to play sport on the weekends. Prof. Mahaboto might disagree with me in terms of that, but it's generally what we find is that they in the middle age, then they decide to play sports on the weekend, and it results in this form of injury. And sometimes, however, they are associated risk factors. Is there anybody who knows that the risk factors for Achilles tendon rupture? It's a bit of a difficult question, I know. So it's always important to list whether there's been any steroid use, whether the patient has been on any antibiotic therapy, more specifically of fluoroquinolones. You also want to know about if they have any comorbidities such as your rheumatoid arthritis, your lupus, or connective tissue disorders. So yes, that's in terms of your history, and always, as mentioned, look, feel, move is extremely important, and always examine the joint above and below, and you manage the patient according to. This is, I think, one of our biggest problems as orthopods is that sometimes it's difficult to manage the patient holistically. We want to go directly to the joint or limb involved. But we make sure that we manage the patient according to 8 principles, and make sure that it's a life over limb situation, and that we examine them appropriately. And in terms of our investigations, as mentioned, we would obviously do our X-rays. It should be concerned of fractures, but the presence or lack thereof of a fracture does not always specifically mean that there is no pathology involved. And so it's always important that should you think there's a soft tissue injury, that you do indeed try and investigate further. MRIs are somewhat difficult to get, especially in the public sector, but an ultrasound will do just fine. And so in terms of the treatment, we do our RICE, as mentioned previously, which is your rest, your ice, your compression, and elevation. Physiotherapy, I cannot stress enough. I've learned over the years the importance of actually sending a patient to physiotherapy. Physiotherapy has so many benefits in terms of muscle strengthening and actually significantly reducing the amount of pain, appropriate bracing for an appropriate amount of time, because in terms of orthopedics, if you don't use it, you lose it. So bracing just for short periods of time, and as well as analgesia. And that's all from me. Thank you very much for giving me this opportunity today.
Well, thank you very much. I don't know if there are any other questions. Thank you, Dr. Swatboy, really appreciate it. If you don't mind emailing me the slides, and we'll put it on the webpage so that people can look at them if they need. The recording will also be on the webpage that you used to register. Any other questions or comments? I'm not sure if Prof. Magubotha is on the call. If you'd like to make some comments before you finish. I think he's not joined us yet.
Okay.
Well, thank you very much. If there are no other questions, I don't see any hands raised. There've been no other comments in the chat. Thank you very much, Dr. Swatboy. Really appreciate it.
It's honestly my pleasure. Thank you for the opportunity.
Wonderful.
And anybody's welcome. I think a lot of I see Tasneen is here as well. You are welcome to give me a call or send me a WhatsApp should you have any questions, or even email Prof. I have got quite a few emails prior, and actually appreciated that. And I think that
Wonderful.
I can essentially assist you in terms of different resources, as should you have any questions.
No, that's good. One of the things, Dr. Swatboy, just quickly while we're on the call, is to be able to get people presenting cases as well, using this opportunity to present a case and say, I've got this patient and this is what I found. How would you manage that? So I think if any of the audience now feels in future that you want a case, please bring it up at these sessions, so that it's not just a teaching, it could be anything that Dr. Swatboy could reflect on as an example, an orthopedic issue. The other thing, Dr. Swatboy, is I'm not sure if your department's using VULA, but we are trying to encourage the interns in the district as well as medical offices to use VULA, registered. It's on your app as VULA Medical. Please go looking at it. It is for family medicine available. So if you are in the district, you can register for a particular family medicine in a particular facility. The family physicians are on Johannesburg overall. And if you have any questions, you can refer to us, or hopefully if Dr. Swatboy is on that as well, you can refer to her.
I'll certainly, I've definitely heard of the Prof, but I've not registered for it. But I think we will after this.
You can find out more and try to register. I think it's a really useful way for us to communicate. Well, thank you once again, Dr. Swatboy. Really appreciate it. And goodbye to everyone. Enjoy your weekend. We'll see you next week. Bye-bye.
Bye.